Okay, now we will discuss the two pathways of pain. Basically, the pain fibers are of two types, fast pain fibers and the slow pain fibers, which are also called as sharp pain fibers and the chronic pain fibers, respectively. The fast pain fibers originate from the type A delta fibers and their velocity is 6 to 30 meters per second. And the slow fibers are called type C fibers and their velocities are zero point 0.5 to 2 meters per second. So, what is the difference of transmission of the two types of pain? Now we will discuss from this diagram. So, as you know, the fast pain fibers terminate on the laminate one of the dorsal horn, and the slow pain fibers terminate on the lamina 4 of the dorsal horn, where they terminate on many small interneurons, and then they both go to the anterolateral pathway and ascend into the brain centers as slow and fast pain fibers. Due to many interneurons in the slow pain fibers, their transmission is slow. Now, the termination of neospinothalamic path. The fast pain fibers are also called as neospinothalamic path. They terminate only in the brainstem and thalamus without further division. The nervous system can localize the fast pain in the body because the fast pain fibers terminate in close association with the tactile receptors. That's why when both receptors are stimulated by a single stimulus, the pain can be localized acutely. The glutamate is a neurotransmitter which is thought to be responsible for the transmission of fast pain fibers. The second one is the slow pain fiber, which is called the paleospinothalamic pathway, and it transmits slow chronic pain. It terminates, as we know, on lamina 2 and 3 in the substantia, which is also called substantia gelatinosa. Signals then pass through many fibers, which are called small fibers or interneurons. Because of this delay, the neurotransmitter for with this is substance P, which is a slow neurotransmitter and it acts slowly. That's why it takes very long to transmit slow pain impulse fibers. The projection of slow paleospinothalamic pathway is on reticular nuclei, tactile area, preaqueductal gray nuclei, interlaminar nuclei. That's why it has many branches and stimulates mainly all the parts of the brain. It has poor capability to localize pain. So these are the basic differences between the different types of pain fibers. Now, the capability of the surgical removal, surgical interpretation of pain pathways. We can, if a person is in severe pain, it is necessary to relieve the pain. So, pain can be relieved by cordotomy, means by the cutting of pain pathways. So, it is possible by it is an anterolateral pathway of the opposite side of the spinal cord is transected to cleave the anterolateral spinal sensory pathway, but it has some restrictions and it is not always successful because of the two main reasons. The first one is the pain fibers the upper part of the body do not cross opposite side of the spinal cord until they have reached the brain. The second reason is the pathways which are normally not very effectual and are too weak to act become sensitized and become effectual. This is a sparse pathway in the dorsal cord. Okay.